Go on with Dr. Faisal Tai. Thank you for coming on. You're the CEO of PsychPlus. And from what I understand, PsychPlus is the largest single appointment psychiatry provider in the nation. Is that correct?
That's correct.
There we go. Love it. So tell me a little bit about you. Did you grow up in Texas? You live in Houston now. You grew up there?
Yes, so I grew up in Texas. Texas is home. I grew up in a small town here called Tomball, Texas. So that was my life growing up. I volunteered at hospitals, went to school up in Iowa, did my training up in Iowa, and then eventually decided to come back to Texas, which is home to me.
Growing up, did you always know you wanted to be a doctor in the medical field, or do you?
No, not at all. I had no desire to be a doctor.
Yeah?
I still struggle with the image of being a physician, to be honest. I don't know. I'm one of those people I could care less if you call me a doctor or not. I know some people are sensitive about it.
Right.
One thing led to another, and I wanted to do something that was challenging, and I always enjoyed biology as a subject, and started studying it and enjoyed it, and ended up becoming a doctor. And one day, was thinking through what I want to do in medicine, and I had always enjoyed the human mind, and that had intrigued me, and and trying to help sort of the patients in this space, and finding satisfaction and finding ways to cope. And so
when you went to medical school, were you going in a different direction and then something changed your mind?
I was going to be a radiologist for majority of my training. And then last year during my interview cycle, I decided to switch last minute into psychiatry. I told myself that if I don't become a psychiatrist, I'd end up regretting this decision. And I couldn't see myself sitting in a dark room for the next 30 years of my life. And so I ended up going into psychiatry.
Well, knowing you, I've known you for about a year now. You don't seem like the kind of guy that would sit in a dark room very well. So,
no.
So was there
not at all?
Was there any like moment that happened that you go, I need to practice psychiatry and not sit in a dark room, or was it just like you were thinking about what you wanted to do, or was there a patient that you saw or something that happened that got you thinking about it?
Yes, there was a specific moment. So I was sitting in the radiology room. And this was fourth year. I had 27 radiology interviews across the country. So, and I was doing my elective. So in medical school, you don't end up doing radiology as an elective. It's not a core rotation. So you don't actually do any of it really until your fourth year. But by that time, it's a little too late because you've already started applying. So I was in the reading room one day. There was a patient that had come in with a cervical fracture. And they're describing what's sort of broken in the neck and stuff like that. And I was like, well, what's the story behind it? Like, what happened that this patient decided? And it's a hangman's fracture. So in radiology, there's a famous hangman fracture. And so I was more curious about what had happened that it led to this incident rather than the fracture itself. Right. And so I was reading those notes more excitedly, or I guess more out of an intrigue or a reason to solve than sort of trying to figure out what do we solve with the fracture itself. Right. And so I've always been the type of person that wants to solve the problem from its source rather than try to patch the symptom. And so there was my sort of epiphany that I think I'm more interested in the story of the human mind and the human being instead of broken bones.
Yeah.
And so I changed from there on and never looked back.
So what does that shift look like when you're in medical school and you're going this way and then you wanted to go into psychiatry?
So I ended up applying late in my cycle into psychiatry. I interviewed at 7 or 8 programs for psychiatry. I ended up ranking all of them above my radiology spots. And I was hoping I don't end up matching into radiology. And so, luckily I got, my top choice. Ended up in Iowa. And I ended up training up there in Iowa. So very extensive program. At Iowa, we had about 110, 120 psychiatry faculty physicians. And so all of these guys, it's a large research institute, ranked pretty high in the country. All of these guys specialists in sort of things that they're doing, from OCD to gambling to eating disorder to borderline personality. And it was an interesting program because while you were training, they would have a different psychiatrist attending every week round with the residents on a different floor. And so in your 4 years of training, you got exposed to 100 different psychiatry minds in terms of, and everyone that's doing research in their specific area. And so, they may be the top 10 people in the world when it comes to that specific branch, whether it's schizophrenia, whether that's bipolar, whether that's treatment-resistant depression, anxiety, you name it, right? And so it was a phenomenal training program. And I think that really set me in a position where I could do what I do today, why I feel comfortable in treating a lot of diverse patients. Some of the guys that taught me literally wrote the textbook for those disease states.
Wow. So one day you'd be going and dealing with eating disorders. One day you'd be going and dealing with people that were in psych units, or
Well,
how did that
you
work?
so you spent the first 2 years on the inpatient units, but the guy that's coming in rounding with you had, even though they're a psychiatrist, they have a specialty that they have spent, the last 10, 20 years of their life researching, right? And so you may go on an eating disorder unit, but patients have multiple illnesses, right? But when you have an anxiety guy coming in who's the world expert at anxiety and wrote the textbook for anxiety, they're really going to give you so much more information on this patient that may be going through depression,
Right.
anxiety, borderline personality, all of it. But really, he will deep dive on the anxiety piece to a level that none of his other colleagues would necessarily, right? And same thing for someone else. And so you really got to see patients in different disease states and really getting expounded on what that disease state looks like, what's causing it, what are the treatment options, all that kind of stuff. So, really, it was a very expansive experience in terms of learning. The sky was a limit when you trained at Iowa.
That's fascinating. And I know you and how you've developed Psych Plus over the years. And one of you guys' big thing is speed to care and seeing a client as quickly as possible. Did you see things back then that were broken? I mean, as I know how you're kind of how you think a little bit so far, and was there an
Yeah,
experience at
so,
that time where you were
so
going, gosh, like,
I was pretty particular on the vision and the mission of this company, and that is pretty simple. That is to end suicide in this country, in this world. I think suicide is one of the most preventable causes of death across the world, especially in the U.S. I don't see how we could be building spaceships going to Mars and this preventable illness we can't put a dent against. I mean, suicide rates have been climbing year over year. But suicide is a fascinating illness because it's not like stroke or heart attack, or some sort of an acute illness that happens within a couple of seconds, right? I mean, when someone is feeling suicidal, that's been brewing for a few hours, sometimes days before they actually act on it. It is rare for it to just happen out of nowhere, right? Like something has been brewing, you've been itching, there's been some issues that have been ongoing. And generally, from the time you started thinking about it to the time you actually do it, you have some time. You may have 24, 48, 30, 72 hours. How do you get a patient in within that time frame, make the access so easy for them? They don't have to think about the insurance. They don't have to think about where they're going. That they can get in to see the highest level of clinician in this space, right? A psychiatrist or a psych nurse practitioner, and just start getting the treatment right away, right? And which is what we do very differently. We don't put you through multiple screeners. We don't do all of this. You talk to someone where you got to fit our mold to be able to be seen by a provider. My philosophy is we are running an all-inclusive platform. Our providers are agnostic to the payer. We take, or we attempt to take, every single payer in the market, including Medicare and Medicaid, because to me, a patient should not have to think whether I have the funding to see the provider. They should be able to come in and see us. And we should be able to see those patients. And there's tons of patients that we end up seeing that may not have a funding source, come to find out later on, but we don't turn patients away, right? Because our mission is very clear in what we want to try to do. I think it's important on why our providers stay with us. I think it's important on why our patients stay with us, is because this overarching mission overshadows everything that we do as a company, right? I remember reading a statement. People ask me, why do people work here? Because it's not the easiest when you're dealing with complex acute situations, when you're dealing with a lot of times patients that may be in a bad position. Sometimes they're calling you, yelling, screaming,
yeah,
because of their illness state, right? Why is it that our retention rates are high? Patients choose to follow up with us. It's because of our mission and what we're trying to do, right? You have two people that go out that lay brick every day. One guy comes home exhausted, does not know what he's doing, in the heat, he's sweating coming home. The other guy comes home, the same amount of work, but he feels satisfied because he knows he's building a monastery, right?
yeah.
And so I think it's important for people to know what they're solving for And I think that allows them to feel satisfied when they're working for us, even as employees, as providers, or as patients that are coming to us. So we try to be very patient and provider centric as a company. And I think that's a big difference between us and perhaps most people out there.
Yeah, that's extremely exciting because my experience has been when someone's in crisis, if they have private health insurance that pays well, it's very easy for them to access services. If they, out here in California, if they have Medi-Cal, they're going to get in line. And sometimes
Yeah,
that's 2, 3, 4 weeks before they're able to see somebody. And like you said, that's too late for somebody that has
that's too
suicidal
long.
ideations. I want to kind of dive in a little bit on just some specific diagnosis and talking to people
Sure.
in the audience that may not really just understand what different things are. And just want to start with depression and just have you tell us what depression looks like if somebody thinks they're depressed, doesn't know whether or not they're depressed, and what they can do about it.
So depression is an interesting illness, right? What's fascinating about mental illnesses today that unlike medical illnesses, they're hard to measure. It's not like a blood pressure that we can put a cuff on you and measure, right? And so there's a lot of confusion on what these disease states look like. And to be frank, I don't think we know everything today, right? I mean, they've isolated hundreds of different of genomic markers for depression, for anxiety, for schizophrenia. I mean, who knows if these are actually separate illnesses that require different treatments, right? I think we are just scratching the surface of what we know about mental health today. Doesn't mean the disease does not exist. It just means that we have to, as an industry, as a community, have to become more mindful on treating it better, right? And mental health has been about 50 years behind other medical modalities, right? If you think of infection and penicillin and oncology, right? They can target that stuff so well today, including heart disease and cholesterol medications. I mean, they know where things are working. For mental health, the funding is pretty recent, and even that, it's minimal, right? Like we are 50 to 70 years behind other medical specialties, which is why we feel primitive. It's not because the space is primitive, it's because the funding has not been there to actually get it up to speed to other specialties, right? So when it comes to depression, it's largely explained by a few weeks of feeling down, not feeling motivated, not sleeping well, not eating well, not feeling like being here. And that is the state of depression, right? Now, there can be environmental factors that could cause depression. You could have genetic makeup that causes you to feel more depressed. But the best way to look at mental illnesses is on a spectrum. They're not either you have it or you don't have it. It's the severity of the illness. I think every human being has moments where they feel depressed. Some people can have, one thing go off wrong in their life and they will get very depressed. And other people could be living in a war-torn zone and they still won't get depressed, right? And so what that tells you is that there has to be some genetic engineering that is causing one person to feel more depressed and another person to not feel more depressed, right? And I think that's really the differentiating factor, right? When your symptoms are lingering on to a point where you are not functional, when you're not performing at an average, above average level, that's when you truly need to get diagnosed with depression and get the treatment for depression. I think it's important for us to be able to classify what we're dealing with, to be able to then treat it, to be able to get that patient out of it, right? And I think that's vital for us to understand as we treat these disease states.
So, as a provider, and you meet with somebody and you've identified they're on the spectrum, some of them with depression, what is the approach? What's the initial approach?
The initial approach is to actually diagnose them correctly, right? And I think that's where sometimes if you're not with a good clinician or you're not getting them to the highest level of clinician care, you can actually waste a lot of time treating things that are not accurate, right? And I'll give you a famous example. I was a resident. I would get a lot of patients that would come into the ER and they would say, I'm having suicidal thoughts. And then you would ask them, well, ask them about their depression symptoms, and it doesn't look like they have depression symptoms. And you interrogate or interview them a little bit longer, and they'll tell you, well, like, I don't think about suicide all the time, but like if I'm driving, I think about crashing my car, or if I'm on the edge of a building, I think about jumping off, or something like that. And I'm like, well, are you feeling bad? Are you feeling like you don't want to be here anymore? No, it's not that. I just get these thoughts. And what's crazy is that's actually not depression. That's OCD. That is obsessive thinking that's causing, and you could have obsessive thinking about anything, right? It could be about cleaning, it could be about 10 different things, numbers, counting, whatever, or you could have obsessive thinking about self-harm, or ending your life or stuff like that, right? Which is not the same thing as depression, and it's treated very differently, right? And so I would get tons of patients that think, oh, there's something wrong with them. They must be depressed. And it's like, no, dude, you just have a loop in your mind that's continually running that is not letting you sort of step out of that loop, right? That's what happens in OCD. Your obsessions sort of run in a loop and you're not able to disattach from them. And so I think the key thing is to actually identify very clearly. It's also true of bipolar and schizophrenia, right? Getting those diagnoses clearly, bipolar versus depression, borderline versus bipolar. I mean, all of these disease states are different disease states.
Bipolar. Describe bipolar to somebody that doesn't completely understand what that means. What does bipolar look like?
So bipolar is an interesting illness, and I think it's most oftenly confused with borderline personality disorder, and these are two different illnesses altogether,
So let's
right?
talk about both one at a time. I'd love to know the
So,
difference.
so bipolar, and the reason why I like to talk about both of them is because sort of a lot of the community confuses them, but they're very different diagnoses. For bipolar disorder type 1, you must have symptoms that last minimum of 7 days or more. And so you'll have patients that may have a symptom, may have mood fluctuations for a day or two. They're not really bipolar, right? Even for hypomania, which is bipolar type 2, you must have symptoms that last for 4 or more days. And so that is sort of a very important factor to note, right? Is the length of the symptoms must be long enough. They're also what we call a disease state diagnosis. And so generally, when we talk about mental illnesses, we classify them in 4 categories. One of them is disease. One of them is sort of multimodal or multidimensional, right? Borderline personality is multidimensional. Bipolar is a disease state. Why it's so important is something that is affected by not just genetic but environmental factors and all of that stuff. Borderline personality disorder or personality disorder in general is affected by that. Bipolar disorder, very different, right? So your traditional case for bipolar is for males it's generally late teens to young 20s. For females, it's late 20s to early 30s. But what's going to happen is you have this normal functioning person that all of a sudden will have a switch triggered and they will go into this manic state or a severely depressed state, which is followed then by a manic state. And then during this state, they start doing bizarre behaviors, that you can't always make sense of. Sometimes they'll excessively drink, they're not sleeping for days at a time, they're doing erratic things which are out of their personality, driving cars very fast, which is not typical for them. If you're just a kid that loves to drive cars fast and you're doing that, you don't have bipolar disorder. Mm-hmm. But if you're a kid, you don't like to break rules, and now all of a sudden you're driving 100 miles per hour, you don't really care if the car flips or anything. You're going in there, you start shoplifting because you're just having fun with it, and that's not your personality. When we see that, we need to pause and get that patient a treatment, because that is generally how bipolar will start, right? They'll start doing bizarre things that don't really fit their personality or their temperament as they're getting older. Bipolar and schizophrenia treatments are a lot, or disease states are a lot similar to multiple sclerosis. That's the closest disease that I can describe to it, right? It's vital to treat it early and fast, because every episode that you have in your lifetime kills your brain cells, and that's a permanent scar in your brain, right? And so the less treatment you get, the more episodes you get, the more dysfunctional you will get as you get older. The aggressive and fast you treat it early on, you have a higher chance of actually making that person a lot more successful in life, right? I have tons of patients, physicians, attorneys that are actually bipolar, that are on treatment, that stay on treatment, and they're high functioning people. So your life doesn't end just because you have bipolar, but the key is to start treatment early, identify it early, start the treatment early, make sure it's treated, right? So that's generally bipolar disorder. Borderline personality is sort of multi-phased, right? Where part of it is genetic, part of it is environmental factors. There's a strong tendency of a history of trauma growing up when you have borderline personality disorder. And so borderline personality disorder is often treated with multiple things. And part of it is going to be sort of your therapies and group therapies and DBT, IOP programs, which are often doing these DBT sessions. and then some level of medications that could help sort of take the edge off, right? But it is really it is a personality disorder that is ongoing, that where medications is not going to be your only answer, right? Bipolar disorder, very different. You can get therapy for bipolar disorder, but that's a lot more going to be dependent on getting on the right meds and staying on those meds, right? With borderline personality, you can actually learn coping skills and better skills to manage your emotions and expressions and whatnot, right? So borderline personality, the better name for it is sort of your emotional intensity disorder, which is different than bipolar, right? Because the bipolar intensity is sort of almost like a disease. Like it is much more intense than your typical borderline intensity, perhaps.
And borderline is just ongoing, where borderline happens in episodes. I mean,
Bipolar
bipolar
disorder
happens in
happens in
episode
much more
more in
episodes than
episodes. Got it.
borderline. Correct.
That
Borderline, you'll
makes
see
sense.
continuous of it. I mean, obviously, a lot of patients with borderline could have bipolar and depression, right? Because these are co-occurring illnesses, or anxiety for that matter, right? But it's important to identify and treat different things in the way they need to be treated. I mean, you can have hypertension and you can have high cholesterol, but these are two different illnesses, right?
Right.
And they need to be treated differently. And so it's important to identify and separate these buckets as we're treating these patients. But yes, borderline personality, usually people start getting better in their 30s and 40s when they have borderline, because whether you go to groups or not, after 20 years of living in your body, you learn how to cope well, or cope to some level. Sometimes people never learn. But the benefit of going to intensive outpatient programs and again starting treatment early is, a lot of borderline patients will have cutting behaviors or self-harm behaviors or maladaptive coping skills, breaking stuff when they're getting upset, stuff like that, relationships that they're burning all the time. The sooner you can get them into treatment and intensive therapy and sort of teach them different behaviors on how to cope with that stuff, the better their life outcomes is going to be, right? If you can teach someone at the age of 17, 18 how to build better relationships and how to not see the world black and white and how to be able to manage the relationships, and there's going to be good and bad, right? And you hopefully will stay married or have a better relationship outcome. You may not burn bridges with your kids and your family members. If you don't do that by the time you're 40 and you learn these skills, well, that's better than nothing, but you've sort of lived a big part of your life and you've sort of missed the opportunity on some of those relationships that may already be burned at this time, right?
Right.
So getting patients diagnosing early, getting them treatment early is vital for us to build better societies and better outcomes for our patients.
All right. A big one that I've run across from coaching high school football and dealing with kids with IEPs is ADHD. What does that look like, and how is that treated?
That's a very interesting illness, and I think probably one there is a lot of confusion about in the community, right? And so ADHD, the fundamental pathology in ADHD is frontal lobe development. So in your brain has four sections to it, right? Occipital, parietal, temporal, and frontal. The frontal lobe of a human brain is the evolutionary wise the most newest part of our brain system. So animals will have less of a frontal lobe, right? Humans have a larger frontal lobe, and the frontal lobe is the part of the brain that also is sort of your inhibition, tells you to stop doing something that you shouldn't do otherwise, right? And sort of the older parts of the brain, right? The parietal, temporal, occipital lobes, these parts of the brain are telling you to do sort of your basic things, right? So to eat, to have sex, to all of this, like the basic innate human things that we do are coming all from our sort of old brain, and our frontal brain tells us, you know what, we shouldn't eat all 8 slices of pizza. I think 1 or 2 are sufficient, right? And so you'll see this, right? Like ADHD patients generally have more obesity issues, right? Because they're hyper eating a lot of times, right? Because their brain is not telling them to stop, right? Or they have other impulsive sort of illnesses co-occurring with sort of their ADHD. But the fundamental thing about ADHD is your frontal lobe is developing slower than your counterparts who don't have ADHD, right? And so oftentimes these are kids that are getting in trouble in school, right? And the teacher is like, well, you must be a bad kid. Well, not really. Their brain is not telling them to not do it, right? And so it takes a lot of coaching and time for them to teach themselves to pause and not just say it, because why not? And I had ADHD growing up, and I still have pretty bad ADHD. I'm too sensitive to medication, so everything gave me a migraine. But I had to coach myself almost to a point to learn how to pause before I say something or I do something, right? And so like your typical ADHD kid, you'll realize, well, they've broken bones, they've smashed their heads, right? Like because they forget to stop, right? Or they'll interrupt in the class, right? The teacher may not even ask them, or they'll say something jokingly thinking it's funny, but no one else finds it funny, right? And this is all sort of characteristics of ADHD kids. Now, sometimes they'll have a high intelligence and high emotional intelligence to be able to cope around it, but that's not true for everyone, right? And so understanding how the disease state works is important, and the treatment is actually very important, right? I know there's a stigma in the community to not treat some of these illnesses. And I think there's a balance between the two, right? You have to look at the severity of the illness. And if it's severe, if someone is ADHD is severe enough to where they're not able to focus in class and they're flunking out of class, or they're not able to focus on assignments, or they're doing stuff that they really shouldn't be doing and is getting them in timeouts or detention at school, well, that will affect their upbringing, and their sort of growth. And so getting them on stimulant medications or ADHD medications, especially at an early age, is vital because it allows your frontal lobe development to get up to speed with your counterparts, right? And so what you learn about mental health is it's actually better to treat it early than later. Because once your brain is developed, you can treat an adult with ADHD. It's gonna take the edge off of the symptoms, but it's never going to actually create the pathways from a neuronal network that should have been created had you taken that medication at an earlier age. And so it's vital to get these kids started on the right medications, get the diagnosis done right, get them on the right medications before they get to an age. So if they're flunking in class, they'll never get the opportunity to get to college, and they'll never get the opportunity to do something great that they could have done, right?
So
And there's certainly bright kids that end up bypassing, right? But
right.
we're all about population health, right? There's always going to be 10% that will survive even without meds, even without treatment, and they were just built for that for that temperament. But your 90% of the kids are not going to do that. And so how do we make sure the population, all of it, is actually elevating as a community and not just the best and the brightest minds out there that have it perfectly aligned for them?
So I've heard that frontal lobe development in males, it goes all the way to the mid-20s, right? Is this something that is
Correct.
ADHD something that people can grow out of after completed development after their frontal lobe, or is it something that's usually always there?
I don't think someone can grow out of it. I think you can learn skills to manage it more effectively, right? I think a lot of it you can learn behaviors. I mean, I'll just give you an example of myself, right? And perhaps like when I sit in, a lot of people don't know this about me. I have a bad habit of interrupting people, and I don't do it out of purpose. I have a thought in my mind and I just say it, right? So like they may still be explaining what they're doing, but I've already figured out what they're saying, and it's already made it to my mouth, and so I say it. And so but I sit in a lot of meetings which are pretty important meetings where I cannot interrupt, right? And so what I've learned to do is actually put my finger in front of my mouth, and I'll just sit like this, so I know
Remind yourself.
if my mouth
Yeah.
has not, if my hand is still on my mouth, I'm not talking, right? And so, but again, like I've had to teach myself that skill set. I haven't grown out of it. I would still do it, but I've sort of taught, like it's going to take me a second to move my hand, and hopefully that second is helpful in processing whether it's the right time for me to say something or should I wait to say it, right? But that's just one example, right? There's hundreds of ways you can learn how to cope. You can certainly go to programs where they can teach you how to cope with some of these things, right? But it's important to learn some of these things, because I do think that real life and society is not going to give you a pass for it, right? And so you have to be able to coach these things. And I think that's one of the unfortunate things about today's society, right? We spend a lot of time teaching kids math and English and social studies and all of these sciences, right? But how much time do we actually spend teaching our kids in school crisis management or learning how to cope with certain things, and, some of your basic emotional regulation things, which would be very helpful, in my opinion, to be taught as a class in school. But unfortunately, that's just not how our society is made up today. And certainly, there are some schools that are doing it better. As a whole community, as a nation, and as a country, and even as a world, I don't think we're doing it much.
No, there's just a stigma around telling people how to behave and how to act, and telling other people's kids how to behave and how to act, and how to process
That is true.
things. Okay, so tell me about dementia. I know there's all different kinds of dementia. I'm experiencing that in my life with older people in my family. What does that look like, and what can be done? And
Yeah, that's a good question. I'll say this, and I don't think a lot of people realize this. So psychiatrists are probably the only one that are trained to treat dementia. So you can go to a neurologist to get diagnosed for dementia, but they don't necessarily treat, or majority of them won't necessarily treat the piece. They'll do the diagnosis. When it comes to the treatment of dementia, psychiatrists are uniquely positioned to actually treat it. But I think most people that have dementia don't even, or family members that have members of dementia don't even think, oh, this patient has dementia, we should take him to a psychiatrist. I promise you, taking them to a psychiatrist and getting them treatment will prolong their life and the quality of their life significantly. There's a lot we can do to try to delay. We can't certainly stop it. We don't have the tools today to do it. There's certainly a lot of drugs coming out. Time will tell how effective they are, right? But what we can do is delay some of the worsening, is decrease some of the symptoms that are associated with it, right? Because what a lot of people don't realize is dementia essentially means that your brain cells are dying. And sometimes when your brain cells are dying, they're accompanied by death of brain cells in areas which are regulating your mood. And so you'll have patients that have dementia that will get more depressed, or will start developing bipolar symptoms. So a lot of times patients' families will often ask me, well, my parent never had bipolar disorder. You diagnosed them with bipolar, at the age of 75 or 78, and they're in the psych unit. And you sort of go through their symptoms, and their symptoms represent a bipolar symptom patient, and they've developed it because of the brain loss that is occurring because of dementia, right? And so making sure that we're treating some of these symptoms that are coming about because of the brain cell loss is important in making sure that these patients are not getting aggressive at home, getting too confused, right? Sometimes you see them, they're not eating, right? Like a lot of times it's because they're getting depressed, and it's not because they have, this like state of depression, they want to live anymore, but their brain cells are slowly dying that are telling them to do some of these things. And there's no other way today for us to describe it but sort of as a state of depression, right? And there's medications that we can give to treat some of these things. And it's important for us to do that. I think it enhances their quality of life. They're much more functional. So I think it's probably one of the most underdiagnosed and undertreated illnesses, which is only going to increase as the population gets older.
Wow, I had no idea that psychiatrists were the only people that were qualified to treat symptoms of that.
Well,
And
we
I don't
specialize in
think
treating
most people
dementia.
know that, right? So
Yes,
yeah.
yes. I mean, so we are the torch bearers of treatment of dementia. Neurologists can make, but they don't specialize in treating, sort of the symptoms that come with dementia.
Okay, let's talk about schizophrenia.
So probably one of the most saddest illnesses is schizophrenia. So, I'll rewind back 1800s, 1900s. There was a psychiatrist that lived in an asylum, a mental health asylum, back in the day when we used to have asylums. This is prior to any medication or treatment being there for schizophrenia, who lived in this asylum for 20, 30 years. And what he realized was there were two types of patients that were coming to him in the asylum. There was a group that was getting psychotic, confused, delusional, and they would improve, right? So they would stay psychotic, confused for months, and then they would feel better and they would go home, and they would stay home for years, and they would come back again in that state. And there was another group of patients that never fully improved. They would have waxing and waning symptoms, but they never got back to baseline. The group that improved, he called them manic depressive, which is in today's world is bipolar disorder. The other group that never improved, he called them dementia precox, because he thought they were getting dementia. So he called them, this is a dementia precox, which is basically like a precursor to dementia, which we call today schizophrenia, right? And so generally what we'll see is, again, it's similar to bipolar and the age range, which is what makes it confusing, is that, for men, late teens to early 20s, and for females, late 20s to early 30s. And certainly it can happen outside of that age range, but majority of the cases will happen within that age range. But patients that are high functioning will start becoming more confused, will start developing odd behaviors, will sort of start sometimes talking to themselves, talking to voices that are not there. And it's important to, again, identify it early and start treatment early. There's many studies out there now which show that if we are able to start the treatment, diagnose early, and start the treatment and get them on long-term injectables, which are tons of them out there now. medications that basically function like a depot shot, right? You give it to them, it can last anywhere from 1 month now all the way to up to 6 months. They have medications that can last for 6 months. And so really that allows them to stabilize as patients, and it can actually improve their quality of life. And wholeheartedly say that probably 90% of the patients that are on the streets homeless are not homeless because they choose to be homeless. They're homeless because of the mental illnesses that are causing them to not be able to function, right? And because of lack of treatment that they're not getting, right? And so really getting them on the right medications and getting them good stable support systems allow them to become functional members of the society, which is important. I've had tons of patients with schizophrenia who have girlfriends, who got married, who have been able to hold down jobs. Now, they're not going to become your rocket scientists that are developing the rocket engine to go to Mars, right? But they can hold basic jobs, right? They can get jobs at convenience stores, at movie theaters, at sort of your basic jobs that will keep them busy and give them a sense and purpose in life, right? One of my attendings would famously say, good treatment for schizophrenia looks like a date on Friday night and a job that I can go to on Monday, right? And which is where we need to make sure that we get these patients functional members of the society.
Post-traumatic stress disorder, PTSD.
So, PTSD is very interesting. And again, this is one of those illnesses that is environmentally based, right? So you have some propensity to become PTSD, and then the environment sort of shapes you in it, right? Because you'll have 100 soldiers that go to war. Not everyone's going to come back developing PTSD. So you must have been prone to developing it to some level to get PTSD, right? And I think it would be amazing at some point if we can find ways to actually study these things prior to putting that person in that environment, because it's not healthy for them, right? Like they will pay the price for that for the rest of their lives. Post-traumatic stress disorder, you usually have traumatic episode in your life, and then you end up developing symptoms that you think that event is still going on, or something that triggers you to imagine that event is still going on, right? And so, it would be a soldier that was deployed for a few years, comes back, fireworks happen, and all of a sudden he's ducking under the car or under the table, and or can't sit except that they're looking at the door, and they're visible every person is visible to them because they're paranoid or worried that someone's going to come in and try to attack them. And so, all of these are symptoms of PTSD. Sometimes it's nightmares, right? And it's not healthy because your brain thinks it's still in a state of crisis and your body thinks it's still trying to survive. Even though you are now living in California and it's sunny weather, you're sitting on the beach, but the wave hits and you're like, well, is this D-Day? Right? Like your brain hasn't adjusted to normalcy. And there's multiple therapies and medications that can help not only take the edge off, but try to get your brain back to a sense of normalcy, right? Specific therapy modalities that have been developed, certainly, intensive outpatient programs that have been developed, but there is treatment for that, and you can improve your life, once that's identified and you get on some level of treatment for it.
What about just general anxiety disorder? And we have on our website that we treat general anxiety. What does that look like?
So I think it's one of the most misunderstood illnesses. And I think what a lot of people think is anxiety happens because of a reason. And I think when you have generalized anxiety disorder, as you get older and as you get to understand your body a little bit, you'll realize that you'll go a few weeks with no issues, and then you'll have anxiety for a couple of weeks due to no rhyme or reason. Like, it's not like your stress level is any different in those 2 weeks that you may be having more anxiety, right? And so the way you see these illnesses, again, is on this waxing and waning sort of, right? Depression, anxiety, bipolar, no matter the illness, right? Is you're not always going to be anxious at 10 out of 10, right? You're going to be, if you have generalized anxiety disorder, you may spend 4 weeks being 2 or 3 out of 10. You may spend 2 weeks being 7 or 8 out of 10. Treatments today that we have don't cure you. What they do is decrease your severity of the symptoms and reduce your frequency of the symptoms, right? So if the medication is working, then if you were getting anxious every 2 weeks out of a 6-week period, maybe we'll be able to cut it down to every 2 weeks out of a 12-week period, or out of a 16-week period. We're not going to be able to take it away completely. And maybe if you were hitting when you got anxious at 7 or 8, maybe we'll be able to bring it down to 4 or 5 or 3, instead of 7 or 8 every single time. And so mental health treatment today is mostly about managing the symptoms and providing a better quality of life rather than curing the illness. because today we don't, again, going back to we don't understand the genetic makeup of this stuff as well as we do for medical illnesses. And so we are a little bit far away until more research is done to really figure out how do we cure some of these things.
Okay, let's talk about panic disorders.
So panic disorder is similar to your anxiety, right? But I'll tell you, a lot of people that have panic disorder have co-occurring anxiety, but it's sort of feeling when you have a panic attack, you feel like you will die. You feel like you can't breathe. It may last 3 to 5 minutes, but that will be the longest 3 to 5 minutes of your life. And it's a bizarre feeling, right? And it's probably one of the most highest causes of ER visits in the country, because you think something is wrong with you. You think you're having a heart attack. You think and it may just be a panic attack. And oftentimes it's because there may be other factors in your life that are happening at that time. And that is how your body's coping with it, is with physical symptoms. And that's generally how we see panic attacks, right? Most of the time when you have panic disorder, it tends to get better, but treatment certainly expedites that process of getting better.
What about sleep disorders?
So sleep disorder is one of the most fascinating illnesses. And I'll share my personal story with this, right? And so I take trazodone to sleep. I'm a pretty big advocate of treating sleep issues. And I'll tell you why. I could never sleep during high school, during medical school. Late in medical school, I started to take trazodone. My sleep improved significantly. And this is me. I mean, like, I'm a scientist, I'm a clinician, I understand the illness, but I'm still a human, right? And I still have to teach myself that which option is better. And so I took trazodone for a couple of years, and a very low dose trazodone. Took it for a couple of years. I was sleeping amazing. I could sleep, 6 to 7 hours good every night, which was never the case. I would always be sleeping 2 to 3, 4 hours, waking up exhausted. I could sleep well. I stopped taking it. I said, I think I'm fine now. A year in, my sleep goes bad again, right? And that's the other thing about psych meds. It takes months for it to fully work, and it also takes months for it to fully stop working. So patients stop taking it for a couple of weeks. They're like, I'm feeling great. Mm-hmm. Well, it's because it's still in your system.
Right.
And it's still, it's still changed some of your brain chemistry to where those cells that it's affected, those cells are not going to change overnight. It takes time for these things to change in your brain. So you're not going to feel it today. You're going to feel it 3 months from today when the medication has been the effects of medication are completely out of your body, right? And so then during residency, I went back on it for a couple of years, and my sleep was better again. Then I stopped taking it because I was like, I think I'm fine. I don't need it. And my sleep got bad again. And then after that, I started taking it, and I said, you know what? F it. Like, I need to stop playing this game with my body and just live peacefully and comfortably. And people ask me, a lot of patients will be like, I don't want to take sleep meds. I don't want to feel like, and I guess I don't see it necessarily that way, right? And I think part of it is understanding human evolution and understanding who we are as a society today. And I tell this to my patients. If you have sleep issues and you can't sleep well at night, it affects your functionality the next day. It affects your growth. It affects your job, affects your ability to make a living. You don't have to take sleep meds. You can go camp in a site where there's no electricity and there's no light. And after 20, 30 days, your body will reset and you will get into a natural state where the sun goes down at 7 and you naturally get sleepy at around 9 o'clock, 10 o'clock. And that's how humans have been for hundreds of thousands of years. For less than 100 years, we've had really electricity, which is like bright white lights, right? Not even, I wouldn't even think 100 years. I mean, really, 1960s, 70s, you still had yellow bulbs, which was a lot similar to sort of your night light that we have today, right? Or like this advent of the way we live today, where you're on your phone till 11 p.m. and you turn off your phone and you turn off your lights and you expect to go to sleep at 11:05. Our brains have not adapted to that model of living, right? 1,000 years from today, maybe so, but today, not so.
No.
Not so much, right? And so if we're wanting to get sleep within the next 30 minutes after we shut off all the lights and we shut off the TV, there's no other way to get past that problem if you're not able to sleep without taking some of the medications, right? And so yes, I mean, and this is true for everything, right? Like, you don't have to take statins if you have bad cholesterol. You don't have to take lisinopril if you don't have bad blood pressure. You can go live, tribe in, Amazon, where they have great blood pressure, where they only eat like nuts and bugs and stuff. Like, they're really living a healthy lifestyle. You don't have to eat McDonald's, but But the reality is, we're going to eat manufactured food. We're going to live in our current state of life. No one is arguing if taking medications is better than living a healthy life 100%. Like if you can live a healthy, organic, stress-free, away from sort of the current hustle and bustle of the world, do it. But most of us don't have the ability nor the resources to do it, right? And so the question really becomes the 95% of the population that does not have the resources, how do they continue to live a quality life despite the environment that they live in? And I think it's important to understand that fact.
Okay, I want to ask you about Spravato. What is it? What is it used for? And let's talk about the evolution of that treatment.
So Spravato is probably one of the best treatments we have today for patients who are having suicidal thoughts constantly. It's still a newer treatment. The medication is pretty old, but the way it's delivered today is fairly new. And I think it's very promising. The way Spravato is delivered now, in most cases, you can certainly get it through IV and you can get it through pill, but most cases you're going to a clinic and there's a nasal puff that you spray in your nose a couple times. And then you sit and watch TV or get therapy during that session for a couple hours, and then you go home and you do this for a few visits, and you start feeling better automatically, especially patients with chronic resistant treatment resistant depression, constant suicidal thoughts. It makes a huge difference in the quality of their life, in how they're functioning, in their suicidal thoughts that are recurring.
Is Spravato, is that, I know there's a lot of studies right now around psilocybin, and that's not legal yet, but what are your thoughts on the research that's being done on psilocybin? And I know that in Oregon, there's like clinics that you can go to.
I consider myself to be a scientist. So if the data is there, the data is there. I'm not anti or for psilocybin. I think in life, everything, whether it's THC or marijuana, whether it's, benzodiazepines, whether it's opioids, whether it's ketamine, whether it's psilocybin, I think everything has good and bad in it. And I think it's important for us to extract the good out of it, especially living in today's age and today's research abilities. It's important for us to be able to extract the good out of it and to be able to regulate it to some level so people are not abusing it. I stay away from saying, all of it is bad or all of it is good. I think there's good in most things that we work with, and I think the key is to finding that balance between what makes sense and what is an overuse or what's considered an addiction.
In some of the PsychPlus clinics, we have TMS machines, correct?
Correct.
Can you explain what TMS stands for and what it does?
TMS stands for transcranial magnetic stimulation. So it's one of the foremost treatments today for depression, especially treatment-resistant depression, when meds are not working for you or you can't tolerate it for whatever reason, right? It's a magnetic pulse that is directed towards a certain part of the brain that is responsible for depression symptoms, OCD, and sometimes even smoking, because a lot of the addiction habits are stemmed from sort of your feedback loop that happens in OCD, right? And so really targeting those brain areas with a magnetic pulse, we've been able to figure out that helps you with your treatment of depression, right? And so it's non-invasive. You go sit in a chair, again, sometimes for as little as a few minutes, and it's a pulsing magnet that's just above your head that's going to be sending some magnetic stimulation, and after a few sessions you start feeling a lot better. So I think it's a fascinating treatment. I think it's only going to improve as we expand our services.
Okay, last question for you. What's your message out there to somebody who's just struggling with their mental health? They don't know where to turn, what to do. What do you tell that person?
I think the key for people to realize is that there is help out there, right? And then you are not fighting this fight alone. I think there's tons of people that care to get people better. I think sometimes the obstacles are significant in getting the care, and I think we shouldn't let ourselves lose hope because of those obstacles, right? And I think reaching out to organizations like ourselves, but there are many organizations out there that are doing the good work and are wanting to help these patients. And so the important message is reach out and get help early, and get on the right treatment early, get the right diagnosis early. Don't wait until things are really bad, right? My biggest frustration is I get calls from people when they're sitting in the ER and they had already attempted suicide, and the question I'm asking to myself is, what prevented this person from getting help sooner, so we could have prevented that ED visit and prevented that bad outcome, right? And so key is to get help early. And if you don't find that one group or one provider is right for you, go to a different provider. There's enough people out there that you will find someone that can understand you, can be sensitive to your approach, and can add value to your life and get you feeling better.
Awesome. Well, that was fun, Doc. Thanks for coming on.
Appreciate it, Chris.
Appreciate you.